everyone, and welcome. We're just a couple of minutes before our start time, so we're going to give folks a couple more minutes just to get logged in, but welcome. All right, good afternoon, everyone. We're so glad that you could join us here for our next in a series of webinars focused on end-of-life care for Vietnam-era veterans. We are very excited to be going over the topic of suicide prevention. Again, much like last time, what we're going to be doing is playing a recording of a webinar that is a VA resource. So again, this is currently up on the TRAIN website right now. The information was in the mailer that we sent out, and we'll be sending that out again, and it'll be up on our website following the webinar. But we just wanted you all to know that it is available there if you are looking for continuing education credits. Otherwise, this webinar recording as well as the slides will, again, as always, be available on the We Honor Veterans website. So again, welcome. My name is Catherine Kemp. I'm the Director of Veteran Services here at NHPCO, and I am joined by my trusty colleague, M. Marge, who many of you work with closely and know and love.
Hi, everyone.
So we will be here running the webinar, answering your questions. Just a couple of kind of housekeeping duties before we get started. Please start thinking about any questions that you may have or any topics you'd like to bring up for discussion. Again, we will be playing the webinar recording, which will last 1 hour. Following that, we will be joined by Dr. Peter Gutierrez, who is a subject matter expert with the Department of Veterans Affairs. So he will be joining us to answer any questions and have a discussion with anything that you all may like addressed. So again, this recording will be available afterwards. We already sent the slides out at an email earlier today to all participants, so you should have gotten those. But again, if not, no worries. They'll be up on our website right after the webinar has concluded. All right, so without further ado, we're going to go ahead and get started.
Director for Analytics at the Veteran Experience Center at the Crescent VA Medical Center in Philadelphia. I'll be filling in for Dr. Scott Shreve and Ryan Weller today, and we'll be moderating the session. The Veteran Experience Center, where I've come from, has taken a large role in this initiative by taking a descriptive look at the clinical and demographic characteristics of Vietnam veterans at end of life and their outcomes. And so we're certainly interested in hearing about the presentation today. So just a few housekeeping items before I turn it over to our presenters. This presentation is being recorded, and I ask that everyone please mute your microphones. There is a chat box to the right of your screen. Please use this to ask any questions, and we will do our best to attend to those during our Q&A session at the end of the presentation. So at this time, it's my privilege to introduce our speakers for today. Dr. Maria Llorente and Dr. Peter Gutierrez, who will be providing a brief introduction, and then we'll begin the presentation. Thank you both for being here.
Hi, thank you so much, and it's really a privilege to be here this afternoon. My name is Maria Llorente. I am a geriatric psychiatrist clinically, and I was very privileged to be able to have had the opportunity to work on the work group that will be doing presentation this afternoon. Dr. Gutierrez?
Thank you, Maria. Hello, everyone. I'm Pete Gutierrez. I'm a clinical research psychologist with the Rocky Mountain Mental Illness Research and Education Clinical Center for Suicide Prevention in Aurora, Colorado. And like Maria, I was very happy to be a part of this work group. And my major contribution was to suicide assessment, which is one of my areas of expertise. So we're looking forward to sharing this training with you today.
So I think we will go ahead and get started. So thank you all very much for participating in this conference this afternoon. The topic of conducting suicide assessments and screening and interventions in order to prevent suicide amongst Vietnam veterans is exceptionally important. And we want to make sure that we are empowering our community hospice services in order to facilitate that process. When we start to think about the majority of hospice care for veterans, it is primarily delivered by community hospice programs in the veteran's home, and most are living in rural areas. Public Law 115-141 directed the VA to undertake a study on the feasibility of implementing hospice care protocols that were specifically tailored to the unique needs of combat veterans, including Vietnam-era veterans, and then to develop a report outlining the techniques, best practices, and support mechanisms to serve these veterans. This presentation is one of 3 that were designed to empower community hospice to better equip their providers with the tools that are needed to provide patient-centered end-of-life care to veterans. So the objectives for this afternoon are to identify the signs of suicidal thoughts and behaviors in veterans, understand and then utilize appropriate assessment tools for defining this risk in the veteran population, choose appropriate interventions based on personal knowledge and experience, discuss options for care related to suicidal ideation both within the VA and then externally, and know how to best care for Vietnam veterans who are experiencing suicidal thoughts and or behaviors at the end of life. So we want to think about why should we identify veterans on admission to a community hospice program. Veterans as a group are a very unique set of individuals. They've had many interesting and varied experiences when they did serve in the military. At the same time, their families may have had their own unique experiences, particularly if the veteran was deployed. And these experiences can play a role in how terminal illness and hospice services are viewed. It's also important to know that veterans and their families may be able to access resources that civilians may simply not be eligible to receive. There are also some studies that indicate that veterans are a high-risk group for dying by suicide, and that can occur even in the hospice setting. A very unique program is the We Honor Veterans. This is a unique partnership between the National Hospice and Palliative Care Organization and the VA. This program offers resources, toolkits, and information to assist hospice providers in supporting veterans and their families. America's veterans have done everything that's been asked of them in their mission to serve our country, and it's never too late to give them a hero's welcome home. Hospice staff may provide the last opportunity for veterans to feel that their service was not in vain and that they are appreciated. Simple acts of gratitude at the end of life can, in fact, make up for a lack of appreciation or recognition during the veteran's lifetime. And this is especially true for those veterans who were never welcomed home or thanked for their service upon returning to in-country. The military history checklist is found on the We Honor Veterans website. This is a short and easy form to determine if indeed a client is a veteran and to find out more information about what that experience was like for them. It will also enable you as a hospice provider to know if the veteran is already connected to a local VA, who their primary provider is at that VA, and whether they are receiving sources of income through the VA system. I'll now turn it over to Pete.
Thank you. Veterans have many experiences while in the military. In some cases, their experiences can lead to long-lasting physical and psychological effects. For example, exposure to firearms discharges can lead to hearing loss, tinnitus, and eventually to difficulty with balance and fall risk. Exposure to Agent Orange is associated with many different conditions, some of which may cause the veteran to now be in a hospice setting. For example, advanced prostate cancer. Enhancing this understanding will enable you as a hospice provider to work with the veteran and family. In this slide, I provide additional information to better understand these military-related concerns. Similarly, exposure to combat can lead to PTSD and associated hypervigilance, difficulty sleeping, irritability, lack of trust, and self-esteem issues. Vietnam veterans have the added stigma of facing insults and criticisms for having participated in an unpopular war. Many continue to experience long-term psychological distress even decades after the war. Sometimes that distress has manifested itself through involvement in the justice system, substance use disorders, housing instability, and financial strain. Asking about these experiences further assists a hospice provider in being able to establish a relationship with the veteran. Thoughts of suicide or a desire for hastened death may be present. Stressors found in the process of getting to know the veteran. Many of the pieces mentioned already in our presentation are risk factors for suicide, such as depression and distress. Sorry about that, I'm off by one slide. This recent study really shows much of the complexity of these concerns, the overlap of mental health, physical health, and thoughts of suicide. Note the conclusion that desire for hastened death among terminally ill cancer patients is not uncommon. So you may already have some experiential knowledge to this effect. You may be asking yourself, considering all these factors, how prevalent is this concern? It's important to understand the data behind older adults and suicide as you're considering your role in prevention. I'd like to highlight in particular 2 points. One being that about 12% of those in home care may have suicidal ideation in the past month, with that growing to 31% in nursing home situations. In thinking specifically about suicide in older veterans, it's important to note the differences and the root causes. The large percentage who use firearms, the most common stressor being medical problems, and the previous lack of standardized process. I'll turn it back over to Maria.
Thank you very much. So now we're going to start thinking about, once you've identified that a given veteran is at risk for suicide, what are the next steps? VA's national approach certainly aligns with the need for hospice. There are several stages to this process. And we can go ahead and move on to the next slide. There is the primary screen that is the PHQ-9. That's the recommended item for identifying those who may be most at risk. The secondary screen. And then, of course, there's the comprehensive suicide risk evaluation.
Maria, I'm going to interrupt just briefly because I think I was supposed to cover these slides.
And so, that's fine, and please be my guest. I wasn't sure if at some point we had, there was a transition that I had missed, but please be my guest.
All right. I'm going to take back over. Apologize, everyone, for our slight confusion. Okay. So let's talk about the primary screening question. This is a single question taken from the Patient Health Questionnaire 9-item version. This is a 9-item screening instrument specifically for depression, and it does have one question specific to suicide, which is what you see on the screen here. There's strong research evidence that people who respond with anything other than not at all are at higher risk of suicide and should go on to the next step of the screening process. In hospice, thinking that you would be better off dead isn't really all that unusual. So it's important to figure out if the veteran feels, quote unquote, ready to die, is thinking that death is imminent because they know that they have a terminal illness, they want to end suffering, or if they are actively thinking about taking action to hasten their death. All of these types of thoughts should be addressed, but only thoughts about doing something to kill themselves should be considered a positive response to the screening question. The secondary screening items come from the Columbia Suicide Severity Rating Scale, or the CSSRS, and there are several versions of this. The one that we're talking about today is the screener version. So this second level screen is for anyone with an initial positive response to the first screening question in the Columbia Suicide Severity Rating Scale screener. Now, while this instrument is mostly used in research, it is also used in clinical settings, and that use is increasing. VA has slightly modified how these questions are asked to make it easier for providers to ask the questions and appropriately interpret patient responses to them. The first two questions ask about thoughts the person is having related to suicide, and the rest ask about specific behaviors in which they may have engaged. These are the 6 questions from the CSSRS, and according to the developers, there is no special training needed in order to administer them. The responses are all color-coded to assist in identifying who is at high risk and therefore should go on to an additional screening. This is a screenshot of what the screener looks like in the VA electronic health record. Each question is asked, and the responses are automatically recorded. You can create either an electronic or a paper form that best fits in with your standard practice and patient flow, so it's easier for your staff to ask all the questions and record the answers. As you can see from the questions being asked, there is really an attempt to understand how far has the person progressed in planning to hurt themselves. To what extent do they have access to the means to engage in self-harm? And have they ever acted on these types of thoughts in the past? Consider the screen as positive if the person responds yes to either question 3 or question 4, or if they say yes to question 5. Question 6 is a follow-up to question 5. It's also positive if they say yes to question 7. Question 8, then, is a follow-up to question 7. At this point, if the veteran has screened positive for suicide risk, a comprehensive risk evaluation is needed. Make sure to follow the processes in place in your agency and/or clinical setting to arrange for a mental health consultation. So, for example, with a psychologist or a clinical social worker to assess the veteran. If the evaluation cannot be done quickly, then take whatever steps are appropriate in your setting, such as additional supervision of the veteran, to make sure that they do not do anything to harm themselves until the mental health consultant can meet with them. But do not err on the side of panic and unnecessarily restrict or at high acute risk of self. A comprehensive suicide risk evaluation is a clinical interview, and as such, there are no standardized questions we recommend using for the assessment. However, it is important that information be gathered on the first 5 bullet points on this screen. Have there been prior suicide attempts? Are there warning signs or triggers that have led to this behavior in the past? What are risk factors that lead to these ideas? And what are protective factors, or reasons the person has for wanting to stay alive? This is also where an open-ended question, such as, can you tell me what got you to the point of thinking seriously about suicide? I'm interested in hearing your story, can be very helpful. The information you gather here will be used to determine the acute and chronic risk of suicide and the best way to address that risk. We'll get into the details of how to do that in the next slides. Thoughts about suicide in and of themselves are neither good nor bad, and on their own, they can't hurt a person. However, the veteran's level of intent to act on those thoughts is what allows you to determine the likelihood that the person will take action to harm themselves. The more serious the intent, the greater the chance of a suicide attempt or death in the near future. All 3 points on this slide are necessary to determine that someone intends to kill themselves. Suicide risk assessment is also not a one-time event, and suicide risk varies over time. So it's important to conduct risk assessment in such a way as to open a dialogue with the veteran, to convey that you have their safety and well-being in mind, and to foster enough trust in you to tell you what they are really thinking. Many of the factors that contribute to a veteran's chronic risk of suicide won't change and cannot be changed. For example, their age, the fact that they have attempted suicide in the past. So this is really seen as their baseline level of risk. Acute risk can fluctuate quite a bit and is often driven by things that can change. For example, their fears about declining physical health or poorly managed pain. It's important that any interventions you decide are necessary after assessing risk are appropriate to their acute risk. For example, the patient who states they cannot bear the physical pain they are suffering anymore and they plan to kill themselves within the next week if nothing changes, requires an aggressive look at their pain management and what can be done differently. Some individuals have long-standing suicidal thinking, and others experience acute suicide risk. The same 3 levels are applied to both chronic and acute risk, and I'll explain these on the next few slides. Many factors can contribute to suicide risk. The essential features in this slide are found when the veteran is at high acute risk. Psychiatric hospitalization may not change the reasons why someone actually wants to die by suicide, but there may be times where hospitalization is the best option for stabilizing someone, giving them some time to be away from the situation that's causing them to feel suicidal, and enabling them to process their feelings so they can benefit from outpatient treatment. In some cases, a treatable mental illness is the cause of the acute high risk, and treating that mental illness, for example, major depression, will significantly improve the person's quality of life and, in turn, their symptoms. In intermediate risk, the essential features are similar to high risk, but in this case, the person is able to maintain safety on their own. How to best address the situation, either through hospitalization or other mental health services, will depend on the results of the evaluation and the resources and support systems available to the veteran. Always use your best clinical judgment to determine the appropriate risk designation and how to respond to it. As you can see, the risk here is lower because the intensity of the symptoms is lower. Remember that risk can and does change throughout the course of hospice care, so assessment is not a one-and-done sort of thing. Some people enter hospice with low desire for a hastened death, and as their disease progresses, they may develop suicidal thinking. Some may start with suicidal thoughts shortly after learning of their terminal illness, but once they begin to adapt and cope, those ideas may diminish and disappear. Each person is an individual. are some veterans who have had suicidal thoughts, with or without making attempts, for very long periods of time. Certain features can increase their risk. For example, use of substances, few support systems, housing instability, or limited reasons for living. Others may be able to verbalize coping strategies and protective factors. Conducting the interview and getting to know the veteran will enable you to better understand the risk level. These are some additional resources that are available to learn skills in managing suicidal risk. More good resources are listed on the next two slides. These slides provide resources specific to veterans with PTSD. And these are additional resources to assist in working with distinct populations of veterans, including those with serious mental illness, military sexual trauma, substance use disorders, and a prior involvement with the justice system. And now I'm going to correctly turn things back over to Maria.
Thank you, Pete.
You're welcome.
So now that we've reviewed assessment, we'd like to provide information on interventions that can be used if indeed a veteran is identified as being at risk for suicidal thinking and or behavior. Developing rapport and using a therapeutic approach with the veteran, as well as thorough screening and assessment, all help to determine and plan effective suicide prevention care. The questions on this slide are critical in assessing suicidal thinking in veterans. I think Lee mentioned in the comments section that pain management or poor pain management actually is a common reason that veterans express suicidality, and that is absolutely true. So is that the source? Is it that the veteran is having some financial concerns, or are there issues regarding loss of control? The fear of the unknown can certainly take over when a person is exposed or is diagnosed with a major health issue, and this can lead to major psychological and emotional impacts, not only on them, but also on their loved ones. As clinicians and care providers, we need to be mindful of the aspects of the life of the veteran that may have affected and, in fact, can even lead to suicidal thinking. These are some questions that can guide us during our work with veterans and provide them with necessary interventions and resources. As Pete had mentioned earlier, the hospice experience is really a dynamic process. It changes over time. Depending on what is happening in the veteran's life, there may be periods of high risk for suicidal thinking, and then there are periods of lower risk. Contributors that increase the risk include social isolation, survivor guilt related to death of close friends or battle buddies, pain control issues, traumatic brain injury, PTSD, spiritual isolation or spiritual pain. In addition, the risk can increase if the veteran feels that they are a burden to others, if they're experiencing loneliness or fearfulness, or are having social stressors. These periods may absolutely be associated with an increase in substance use disorders, and that's an additional consideration. This slide provides a host of tools that can assist the clinician in understanding the veteran and understanding and helping the veteran to understand their own personal goals. The Personal Health Inventory is a self-assessment that helps the veteran articulate what matters most to them, what brings them joy and happiness. Completing the self-assessment can help guide the veteran and the clinician as they explore and discuss the veteran's priorities and values in key areas of their life. This information informs discussion to link life goals and health goals, a defining step in practicing whole health care. The Personal Health Inventory will help the veteran explore these areas in life that affect their health, It can include things like sleep, diet, relationships, their environment, and more. It will help them assess the 8 components of self-care that have been recognized by the World Health Organization to affect health outcomes. The Cleveland Clinic video offers a unique method of learning more about working with healing and patient care. It builds a connection that encompasses mind, body, and soul. It assists the provider in being able to stand in someone else's shoes, hear what they hear, see what they see, feel what they feel. And would you treat that person differently if you were looking at it from their perspective? Similarly, the Cleveland Clinic empathy video really brings into the forefront the impact of a diagnosis and its effect on a human being. When you're in the hospital, everything changes. You depend on others for just about everything. Each word, each touch, each visit really matters. Cleveland Clinic's empathy, the human connection to patient care, tells part of this story. You'll be moved by these life-changing stories and astonished when you learn what the patients have in common. The suicide assessment by nurses is an article that spells out the role of nursing in suicide risk assessment. Most registered nurses have had little or no training in how to assess, evaluate, treat, or refer a suicidal patient. And because of this, nurses sometimes feel ill-prepared or afraid even to talk to patients about suicide. The purpose of this article is to review the state of the science of suicide assessment training specifically for nurses. And it trains nurses in how to assess, evaluate, treat, and refer a suicidal patient in order to be able to prevent suicide. Research has suggested that once nurses are trained in this process, they realize that it is no different than assessing for other types of illness, and they are in fact able to successfully help those with suicidal tendencies. The article offers implications for education, research, and practice in its conclusion. As you all may know, communication is really a learned process that is influenced by several factors. These can include environment, the relationship between the sender and receiver of the communication, the content of the message, and the context in which the message takes place. Many other factors also have an impact. These can include the attitude, values, ethnic and cultural backgrounds, socioeconomic background and status, family dynamics, life experience, knowledge level, and the ability to relate to others. There are various types of communication that can take place, including social, collegial, interpersonal or self-talk, and focused interpersonal communications. This is the transaction that typically occurs between 2 or more individuals. There are many considerations which can influence communication. Therapeutic communication and interpersonal relationships are critical components that have typically been used within psychiatric mental health nursing for decades. And training these skills can be utilized by clinicians in all areas. Using therapeutic communication may help develop or improve positive therapeutic relationships and trust with veterans. As we all know, communication is the primary mechanism which healthcare providers use to share information, convey assessments and plans, and make decisions. However, trust is built through applying therapeutic communication techniques, which can involve using open-ended questions, active listening, and empathy, all of which help to promote engagement of patients in discussion and decision-making regarding their own care. We know that trust is the foundation of relationships, and no matter what areas you're practicing in, establishing a therapeutic relationship is a critical component of effective care, which helps to form the basis of trust between the clinician and the veteran. Trust is also established through the clinician's presence, their reliability, integrity, and desire to offer help. In addition, self-awareness is critical in establishing this therapeutic relationship, and it's critical for the nurse or a clinician to acknowledge and be open to reassessing their own beliefs, which can certainly have an impact on the interaction with the veteran. Establishing rapport with the patient is a primary task in relationship development. It's that getting acquainted period in which trust is formed and established through a warm, friendly, and non-judgmental attitude. Showing respect and dignity is a critical component in this relationship. It's about showing an unconditional positive regard for the veteran as a worthwhile, unique person. Respect is demonstrated by asking how the veteran prefers to be addressed, spending time and allowing for concerns and questions to be voiced. Respect is also demonstrating by providing and protecting privacy. Empathy is demonstrated by the ability to perceive the meaning and feeling of the veteran and to communicate that understanding. It really is an essential skill in healthcare. Active listening involves interactive, non-judgmental process that requires the clinician to be attuned for facts as well as underlying meaning of the patient's communication. It requires the clinician to accurately interpret the patient's responses, give feedback demonstrating understanding of the veteran's message, and can involve both verbal and nonverbal behaviors. This type of communication can ultimately help to promote the veteran's trust. There's also a video that's included as one of the resource material links on the slide, and this offers information regarding the application of therapeutic communication through several vignettes that involve nursing staff and veterans. Many Vietnam-era veterans who were exposed to combat may experience PTSD, which includes symptoms of hyperarousal, feelings of powerlessness, ongoing hopelessness, and a constant state of alert due to dysregulation of the neurologic and endocrine responses that trigger these behavioral symptoms. It can also be associated with irritability, anger, aggression, anxiety, impulsivity, and often suicidality. Repeated threats or exposure to stress, combined with this dysregulation of the nervous system, can increase the veteran's inability to respond to stress, and subsequently they can exhibit hyperarousal states. These hyperarousal states, as well as exposure to the acknowledged presumptive diseases, such as the many cancers that are associated with exposure to Agent Orange during the Vietnam War, can also produce feelings of betrayal of trust and a loss of safety. Because PTSD includes multiple mental health coexisting disorders, such as depression, anxiety disorders, and substance use disorders, veterans are at particularly increased risk for suicide. This is why it's so important for clinicians to be alert for symptoms of PTSD, as well as develop skills to address the immediate safety needs of a veteran in crisis. There are various ways to connect the veteran with your local VA. As we heard in the first round of slides, the military history checklist can provide you the information as to whether the veteran is already connected or not. If they're not, the first link on this slide takes you to the va.gov website and the facility directory. The second link provides information on how to access mental health specialists at the VA, including telehealth services that are often available to connect with veterans on their terms. If the veteran, for example, is unable to make it to the VA facility for an appointment, sometimes a smart device can offer an online appointment, and there are other avenues to be able to provide telehealth services even in the veteran's home. Suicide prevention teams exist at each VA facility and at some of the larger community-based clinics, and they can provide services as well as monitor and track high-risk patients in order to assure that an enhanced level of care can be provided. These teams can also be accessed through the VA's website. Within the hospice setting, chaplains have a particularly unique role. They have specialized training in listening carefully to the patient's story. They focus on the source of meaning, purpose, hope, and connectedness to the self and to others, as well as to a higher power. And the patient enables him or her to think about the worth of their life. The chaplain listens for a patient's joys and sorrows. If a patient talks about spiritual distress, for example, my life has no value, the chaplain explores what that or words to that effect mean to that person. Are there any surviving sources of inner strength that the patient may have despite their hopelessness? What are those? The chaplain, using narrative and interpersonal understanding, can help to refocus the patient on positive inner or external resources. Are there hints of suicidal ideation? Do they seem acute or severe? While a chaplain is not a mental health professional, he or she can pick up on clues that may necessitate the referral to a mental health specialty provider. Moreover, a professional chaplain is usually integrated as a member of an interdisciplinary care team and can, in fact, share within that confidential body which patients may be at risk. Chaplains are trained to establish positive trust relationships with spiritual care recipients, and this trust opens up easier and frank communication. Veterans have experience confiding in the chaplain, and that may not be the case with other people. The chaplain is a valuable resource in suicide prevention. Suicide safety planning is an effective and valuable brief clinical intervention. The plan is a prioritized written list of coping strategies and sources of support that the veteran can use at times of crisis or distress. The intent of safety planning is to provide a predetermined list of these coping strategies, as well as a list of individuals or agencies that the veteran can contact in order to help them lower their imminent risk of suicidal behavior. It is a therapeutic technique that provides patients with something more than just a referral at the time of a suicide risk assessment. By following the predetermined set of coping strategies, social support activities, and help-seeking behaviors, veterans learn and can determine and employ the strategies that are most effective. This approach is consistent with the recovery model, which views veterans as collaborators in their treatment, and it helps to foster empowerment, hope, and individual potential. The basic components of the safety plan include, number one, recognizing the warning signs to signal the possibility of a suicidal crisis. Number two, identifying and employing internal coping strategies without needing to contact others. And then number three, utilizing contacts with other people as a means of distraction from those suicidal thoughts and urges. This can include going to healthy social settings, such as a coffee shop, a place of religion, or socializing with family members or others who can offer support without even necessarily discussing the suicidal thoughts. Another strategy includes contacting family members or friends who may help to resolve the crisis. Number five, contacting a mental health professional or a mental health agency. Number six, reducing the potential for the use of lethal means. Patients are instructed first to recognize when they are in a crisis and then follow steps 2 through 5 as outlined in the plan. If following the instructions outlined fails to decrease the level of suicide risk, then the next step is followed, and then the next step, and so forth. In general, safety plans should consist of brief instructions that use the patient's own words and should be fairly easy to read. The links on this slide are to the safety plan template and an associated manual that can be used and serve as a really wonderful resource. A study interviewed people who survived suicide attempts and found that in about half, there were only 10 minutes between the appearance of suicidal thoughts and the person taking action on those thoughts. This period of, quote, crisis, unquote, is often very brief. A highly effective strategy is thus to increase the amount of time between the first thoughts of suicide and that ability to take action. This additional time can facilitate reduction in impulsive acting out. It can bring attention to the veteran's distress so that other people can help, and it can even help the veteran reach out and implement their safety plan. Further, limiting access to a means that are more likely to be lethal has been found to reduce completed suicides. The greater the period of delay, the greater the chance the suicidal crisis will pass. Lethal means counseling is an evidence-based strategy for suicide prevention. The provider working with the veteran emphasizes the provider is very concerned about the veteran, explains that reducing access to lethal means can prevent suicide, and then works with the veteran and the family to develop a plan to help the veteran be safer. Strategies that have been found to be successful include restricting the quantity of medication immediately available, either through providing smaller prescriptions or through the use of blister packs that take a longer period of time to open. Keeping medications locked, properly disposing of medications that are no longer being taken or needed, the use of firearm locks, storing ammunition in a separate location from the firearm, especially in locations that require some travel and or social interaction, and then putting time and distance between the veteran at risk for suicide and the lethal means. The reference above in the slide provides additional information for lethal means safety and recommendations. The last resource is an online course for clinicians that is sponsored by SAMHSA on lethal means counseling. It's free of charge, and it includes handouts for clinicians, patients, and caregivers. There are other available interventions to alleviate distress that can lead to suicidal thinking and behavior during the end-of-life period. Basic options can include asking the veteran questions about their customary routines before they became ill and after illness. This can help the provider to identify things the veteran values, as well as those things that he or she can still do, and interests that can provide them pleasure. Some veterans are very technically aware, while others may not be. Sometimes providing them information and basic assistance in the use of smartphones or other electronic media can help them connect with friends and family who may be geographically distant. A form of therapy called dignity therapy may be available in your area, and there may be local workshops to whom you can elect to send some of your staff for training. This is a life review psychotherapy where the veteran is asked to write down important memories and then is given an opportunity to leave these messages for their loved ones. The therapy invites individuals with life-limiting illnesses to reflect on matters of importance to them. There are other available interventions to alleviate distress that can lead to suicidal thinking during the end-of-life period. Basic options can include asking the veteran questions. Behavioral activation is one additional strategy that can help individuals who are experiencing suicidal thinking and can enable them to engage in pleasurable activities and social interactions. The goal is to learn what are the specific skills that can help to increase engagement in everyday positive activities. This in turn will lead to more positive reinforcement for the veteran and less depression and dysphoria. Behavioral activation can also impact negative thinking processes, since now they're doing more than they thought they could. And that can also increase and improve their sense of overall physical well-being. Some examples include listening to music, spending time with grandchildren, meditation, engagement in religious activities, reading, and playing cards. You can see that most of these are things that even an individual who is quite ill and perhaps not able to get out of bed would still be able to engage in. There is a large list of activities available at the website on the slide. An additional therapeutic intervention is a hope box, and this can be a real box or it can be a virtual box. Loss of hope is a recognized determinant and contributor to suicidal thinking. A hope box is a way for the veteran to remember their reasons for living no matter the time of day. They're asked to find a container, and then they take the time to put items into the container of significance. Things can include a CD or a DVD, lyrics of a meaningful song, quotations. There are inspirational, military themes or slogans, challenge coins, letters, text messages, medals, anything that is of special significance or value to the veteran. The remaining slides in the deck have multiple resources, including some information on telemental health initiatives and the various methods by which an individual might be able to access telemental health services, again, even from the home. And then it also offers, of course, the Veterans Crisis Line for free, confidential, 24/7 support. I think we will stop at this point and see if there are questions or comments from the group.
And Maria, before we do, I am going to go one more slide forward and just quickly highlight a resource for community providers so long as they are working with veterans, and that is live phone consultation with myself and my colleagues here in the MIRIC. And this slide tells you how to submit a consult request. It's totally free, and you can use it as often as you like when you're concerned about suicide risk with any veteran with whom you're working.
That's great, Pete. Thank you so much for doing that.
Of course.
There was one question that popped up from a participant regarding the Baker Act and what role that might play. One of the comments was that they don't have Baker Act. They don't Baker Act anyone at hospice. So I was wondering if either of you had any comments about that.
Yeah, so the Baker Act is the law in the state of Florida that describes how you go about involuntarily committing someone to get a mental health assessment. The first thing that I would say that's very important for everyone to keep in mind is that every single state has a different law as to what are the criteria for involuntary mental health assessments and who can initiate an involuntary mental health assessment. So the Baker Act, as I said, is unique to the state of Florida. Because we're dealing with community hospice providers, it's extremely important to understand what is their standard operating procedure, what is their protocol for how to manage a suicidal patient. In some cases, they may have a protocol where they notify the attending physician. They may have a protocol where they're instructed to contact a supervisor. It may be where they may be instructed to contact the police or a paramedic. So every hospice program ideally will have a protocol that their staff are to follow. I hope that's helpful.
Thank you. Are there any other questions from the group?
Well, I see there's been some discussion about blister packs and whether or not those are available through the VA pharmacy, and one attendee said not at their VA. My experience is that varies from pharmacy to pharmacy, and so it's certainly worth asking your local VA pharmacy about that. There's two different types of blister packaging systems. There's a cold pack system, which is pretty inexpensive and pretty easy to do, doesn't require any special equipment other than the blister packs and the backing. So I would encourage you, if that's something that you're considering for a veteran you're working with, just check with the local pharmacy. If blister packs aren't available, pill boxes are a decent alternative. They don't have all the benefits of a blister pack, but they are helpful as well.
Great, thank you so much for bringing that discussion back in. Another great question that just came in is, will veterans need to be enrolled in VA to receive telehealth mental health services?
Yeah, that is a really good question. And the short answer is yes. The slightly longer answer is that remember that now there are many veterans that have, because of the new access rules under Mission Act, there is much greater access to be served by community providers. But in order to receive services from a VA mental health provider, and especially to be able to access some of the VA Connect options where they can be seen, through video devices in the home, yes, those would require being enrolled in the VA and then getting the equipment from the VA.
Okay, thank you.
I saw where there were also some questions about the gun locks, and typically gun locks are available at the VA, but it may vary from facility to facility who has the gun locks. At most facilities, certainly the police service will have them. In a lot of the facilities, the suicide prevention coordinators also will have them. In some facilities, primary care providers will have them in their offices and be able to distribute. There are also several events that occur throughout the year. If I'm not mistaken, I believe September is typically Suicide Prevention Month, May is Mental Health Month, and a lot of the facilities will offer events where they're distributing the free gun locks during those events as well. So it may be that at the time where someone reached out to ask if there were gun locks, it could have been like immediately following one of these events, and maybe all of the gun locks had been distributed, but they are typically restocked. And again, the most common resources are police service, suicide prevention, and in some cases, primary care.
Great, thank you. Another question, are there any videos or presentations where a veteran who failed to commit suicide has shared his thoughts and what could have been done by friends or family?
Yeah, I'll take that one, and I'd like to start with a brief corrective. The term failed suicide is really not something I recommend saying for all kinds of reasons, the least of which is the person is still alive. That's not a failure. So we talk about surviving suicide attempts. I'm aware of 2 films that are being made about veteran suicide prevention that do involve survivors of suicide telling their story, but I don't believe either film is out yet. There is, however, a fantastic website called Live Through This. It's just livethroughthis.com. It's not veteran specific, but it's photographs and stories from well over 100 individuals who have survived suicide attempts, and I think that some of the stories on that website may actually be quite useful for hospice providers to be aware of.
Great.
And I think that SAMHSA also has a website where several different people who are suicide survivors tell their stories. And if I'm not mistaken, I'm not sure if the person is still on that website, but I recently accessed it, and one of the individuals telling their story was a veteran.
Another participant just commented there's a great documentary called 72 Minutes on Vimeo.
Oh, thank you. That was actually
Thank you.
one of the two films I was thinking of, and I wasn't sure if it was out.
Great. Great, thank you. I don't see any other questions coming from the group, and we're approaching the top of the hour.
All right, everyone. Well, that concludes the end of the webinar portion. I do want to go ahead and introduce Dr. Peter Gutierrez, who is joining us. Peter, can you hear?
I can. Can you all hear me?
Yes, loud and clear.
Excellent.
Well, thank you again for joining us. If possible, could you maybe give another just quick introduction to yourself, your role, and some of the work that you do as well?
Sure. So it was a little fun listening to the end of this webinar, since that was me on the recording. So just in case any of the attendees weren't paying attention at the beginning, got on late, don't remember, I am a clinical research psychologist in Aurora, Colorado. I'm with the Rocky Mountain Regional VA Medical Center, and I'm in our Mental Illness Research and Education Clinical Center for Suicide Prevention. So we are one of the VA's two centers focused on suicide prevention, the other one being the Center of Excellence at the Canandaigua VA. So I was a part of the team who put together the training that you just heard, and been involved in suicide prevention research for over 20 years. I co-direct the Military Suicide Research Consortium with my good friend and colleague Thomas Joyner at Florida State University. And this is a very large Department of Defense funded effort focused on suicide prevention research for active duty military and to a lesser extent veterans. And I will do my best to answer questions, and those that I can't, I'll punt back to Catherine.
Thanks. Well, again, everyone, feel free to enter any questions in either the webinar chat box or in the Q&A section. So we do have a few so far. I will start off with the most frequently asked one. Will the slides and recording be available after the webinar? Again, yes. This will be posted on the We Honor Veterans website. I'm going to say within the next 2 to 3 days. Give us a couple of days to get it up, but the recording as well as the slides will be available, so do not fret. So on to the next question. Do you find compassion fatigue or secondary trauma to be an issue with treating clinicians?
Absolutely, and that is one of the main reasons why the motto for the MIREX Suicide Risk Management Consultation Program, the slide that is still up now, is never worry alone. It is stressful working with suicidal individuals, and it is tough if you feel like you're the only one who is worried about a particular patient, or the burden for trying to keep that patient safe you feel is falling solely on your shoulders. So several things that we recommend that can help with that is to take advantage of both formal and informal supervision that's available. So find a trusted colleague to talk about your concerns with, just to bounce ideas off of. Talk with your supervisor. Whatever whatever it takes so that you're not worrying alone. And then in addition to that, you can absolutely submit a consult request with our service. And not only do we consult with clinicians who are working with currently suicidal veterans, but we also consult with clinicians after there's been a death by suicide, which of course I hope none of you experience, but you certainly may. And we have a member of our team, Dr. Sarah Nazem, who is a national expert in suicide postvention, which is care for those after a suicide death. And so we have a host of resources that we can make available to you, and certainly happy, well, not happy that someone died, obviously, but happy to consult with folks in the event that you have experienced a suicide death and you need to talk to someone about that.
Thanks for clarifying that. This is another question that I think comes up quite a bit with our community providers. If a veteran is on hospice and needs mental health services for being suicidal, can they remain on hospice while getting services from a mental health provider? Same with if they are hospitalized for a mental health crisis, can they still remain on hospice?
I'm going to have to defer to you, some other smart one who's attending, to answer that, because I don't work in hospice. I don't know.
All right, as far as, just to answer this, and I can confirm and then get back with you, Erin, but as far as I know, yes, if you have a veteran under your hospice service and they do need mental health support services, they may still remain on hospice. So let's see, next question. Would you suggest using the extended screener for all vets in hospice, or only if they trigger the initial PHQ-9 question?
I would not recommend just universally using it. That's not how it's designed to be used. Starting with the initial PHQ-9 question, as you would in any other setting, is what's recommended. There's probably not much utility in going through the entire assessment if they don't screen positive to begin with.
In my experience with some Vietnam vets in hospice, specifically those who saw active combat, want little social contact from anyone as possible. They decline chaplain visits, social worker, and they continue to socially isolate themselves and have a minimal personal support network. Any suggestions for supporting those patients?
Yeah, I think that experience is quite common, and it definitely, it poses a challenge for a lot of reasons. I mean, something that can potentially be helpful for the more socially isolated veteran is to even, I mean, if they're in a hospice facility, to just encourage them to not spend all their time by themselves in their room. If you think about, the safety planning process that was talked about earlier in the webinar, one of the steps on a safety plan is to be around other people, but not necessarily having to interact with them. So, of course, ideally, we would like people to be really socially engaged with one another, to have, meaningful relationships, people that they can talk with, people from whom they can receive and give back social support. But, for veterans like the one you describe, who really don't have any interest in that, and trying to engage with other people might make them feel worse, at least trying to encourage them to be around other people can be helpful. It's also worth exploring ways that they're interested in connecting with people that don't have to be face-to-face. So, are there people who they stay in contact with by email, or do they use other, communication technologies? So I think, as with so much in good patient-centered care, it starts with, a conversation with the veteran about what are they willing and able to do, and maybe encouraging them to move a little bit outside their comfort zone, but not to push too far, and hope that, something is viable, so that they're not just completely socially isolated and no one knows, how they're doing because they're just not talking to anybody.
Okay. So next question, would you recommend assist training for hospice and palliative care providers, so RNs, social workers, CNAs, et cetera? I know they are offering it for both active military and veteran groups in Louisiana, as well as for free to the community. So is this or any other trainings that you would recommend?
Assist training is very good. There are other gatekeeper trainings out there. Some are more, well, I don't know if any are more detailed. Some are less detailed. So question, persuade, refer, QPR is another one. I certainly don't think it's a bad idea to get additional training. I'd say it, really depends on what will fit in your skill forward. But it certainly is. It's good. It's widely available, and there's certainly nothing in that training that would be run counter to anything that you've heard in today's webinar.
All right, next question. What are some of the reasons that veteran or military suicides continue to increase? And I'll tie that into another question that someone had was, have you seen an increase because of the opioid crisis and epidemic in our country?
Yeah, if I knew the answer to that question, I would be able to work myself out of a job and I would be really happy. Wow. Nothing has changed in terms of how complicated and multiply determined a problem suicide is. Is the opioid crisis contributing to it? Most likely. Certainly other things going on in the last 5 to 10 years are probably also contributing to it. So, the answer to that question really depends on, are we thinking about public health solutions or are we thinking about individual level solutions? And the answers really are quite different. And since this, webinar is focusing on veterans in hospice care, I think it probably makes more sense to focus on individual level answers. And fortunately, for preventing individual suicides, the information in this webinar is really, I think, quite good. The better you know the veterans you're working with, the more aware you are of their personal reasons for thinking about suicide, as well as their personal reasons for wanting to stay alive, the more that you can do to address those reasons so that you eliminate or decrease the strength of the reasons that they have for wanting to die by suicide, and increase or strengthen the reasons for wanting to stay alive, the more likely they are to not die by suicide. But in terms of, population level, there's all sorts of things, but, that could be a webinar in and of itself, or two.
Okay. Next one, starting out with a good comment. Thanks for discussing the positive roles of chaplains in the realm of end-of-life care. I'm curious about issues related to guilt and shame over things that they've seen or done that seem to be emerging in greater numbers for veterans at the end of life. Are you seeing this as well?
Yes, and in fact, there was a senior VA chaplain who was part of the work group who collaborated on this training, and that was something that that he talked about quite a bit, and that's where his input on those interventions to specifically address guilt and shame came from. So. Yeah, I think chaplains play a really important role in suicide prevention. I also think that chaplains have unique training and experience to address guilt and shame, and so you know, absolutely, in your particular setting, don't forget about the chaplains. Take advantage of their expertise and you know, consult with them as well, because I think that their role is really quite large.
Okay, so someone posted, I am a volunteer coordinator that has a vet-to-vet volunteer program, helping our volunteers identify suicide thoughts in our patients. Would you recommend a happy box instead of a hope box, knowing death is in the near future? And someone actually responded to that question. I would suggest that hope is not an invalid concept in the context of life-limiting illness. Hope can be restructured in the context towards more relevant goals. Hope should never be abandoned, so I would not recommend a happy box instead. To me, that abandons hope in favor of a platitude. Ooh, any thoughts on that one?
Yeah, it's both a really good question, and I like William's response. I've never heard hope boxes or hope kits referred to as happy boxes, and I think that's probably in part for the reasons that William listed. The other reason, I mean, the main reason that it's referred to as a hope box is that in you know, in research on factors that contribute to suicide, hopelessness is one of the sort of strongest correlates of suicide. And so hope boxes come from cognitive therapy for suicide prevention, which is an evidence-based psychotherapy for individuals who have recently survived a serious suicidal crisis, often a suicide attempt. And the intention behind a hope box is to make it easier for the individual to remember those things that give them hope. Because as William said, hope is relevant no matter what. And so that's why it's called that. And so the rather than renaming it, I would, you know, again say that what's most important is the personal relevance of the items that are put in that hope box, and that you know, work with the veteran to help them think of as many things as possible to put in that box to help them maintain hope. It also serves as kind of a nice metaphor of carrying hope with them until they feel less suicidal. Because whether it's a physical hope box, which is often a shoebox or a, you know, plastic toolbox or something like that, or the virtual hope box app, the smartphone app, either way, it's something that the person can carry with them. Although I will say that the research that was done on the hope box app, one of the things that participants in those studies consistently said was they liked how portable it was because it's on their phone, and it's easier to take with them literally wherever they go. But people also said that having the tangible items in a physical hope box was meaningful, that there's something about For example, holding a letter from a loved one in your hand and being able to read it. It's a different sensory experience than even reading the same text on the screen of a phone. Or holding on to a commander's coin connected them with, the person they got it from, the reason they got it in the first place, maybe in ways that a picture of it on a phone, wouldn't function. So that wasn't really the question, but I'm big on answering questions in ways that I want to convey things that I don't think have been covered yet. So I'm okay with that.
Much appreciated. Okay, so one comment we had from an attendee: in response to the increase of suicide ideation in Vietnam vets lately, from personal experience, it seems that memories and symptoms came flooding back after the veterans retired from their jobs. They expressed they worked so hard for so long to keep all of the thoughts and feelings down, but then when they retire, they are overwhelmed. And this is just from their personal experience, meaning loved ones in their family that are Vietnam vets. Is that something common that you see as well?
Yes. It's not specific to Vietnam vets. So the broader experience that's being described here, which is an increase in suicide risk at major transition points, and retirement is certainly a major transition point. That's pretty universal. And so, thinking about older adults who have recently retired, that's a huge change in the amount of structure in their life, in having something to do every day that gives them a sense of meaning and purpose, in feeling like, they're a valuable member of society, that they're making a contribution. And all of those kinds of things can absolutely contribute to an increase in suicide risk, which is why, one of the things that we recommend in terms of, monitoring changes in risk is to pay attention to those big life transitions. For younger veterans, it could be things like their children, leaving home, going off to school or moving out on their own. Certainly the end of a significant interpersonal relationship. Lots of things would count as transitions. But then as far as there being an association with thoughts and feelings that Vietnam veterans in particular maybe were better able to keep in check when they were working, when they had more distractions. I think that's probably the causal mechanism. Is they went from having structure 40 hours a week or more, having things to do that were distracting, to now all that is gone. And so I think it certainly makes sense that you would see a big surge in those kinds of thoughts and feelings. And so learning other coping strategies is probably, going to be quite helpful for that.
Good. So do you have any questions for our attendees or participants that maybe they could answer, or is there anything else that sort of frequently comes up that maybe no one had a chance to ask?
Well, I often get asked about how useful are screening tools and assessment tools for predicting suicide. And I actually can't remember the extent to which that's addressed in the webinar, because it's been a while since I've looked at the slides. So if I'm repeating myself, forgive me, but it bears repeating. We cannot do a good job of predicting who is and isn't going to make a suicide attempt or die by suicide based on even the best current assessment tools. And that's why it is so important to be doing individually tailored assessments and getting as much information about each veteran you're working with as you can, ideally from multiple sources. Because even though you can't just administer a measure, score it, and then look at the score and say, oh, well, this person scored a 20 on this 25-point measure. That means they're probably going to make a suicide attempt soon. We don't know that. But we do know that people who score higher on well-validated measures like the ones that we talked about in this webinar are absolutely, their risk is higher. And so as a result, the level of care that you provide to them needs to be tailored accordingly. So I spent a good chunk of my career trying to, develop measures that could predict really well. And I've pretty much given up on that. So I'm now much more interested in the approach to assessment that we talked about in this webinar and ensuring that, as I said a moment ago, the specific reasons why each individual veteran you're working with wants to die by suicide and figuring out what you can do to address those reasons.
All right, any other questions from the attendees or any parting words? Not seeing anything else come in, but again, anyone who's on the webinar, if you think of anything, please feel free to email us and we'll get you an answer as quickly as we can. We've had a lot of people typing in. Thank you, very informative. So thank you again so much, Dr. Peter, for joining us. I know all of our attendees really appreciate it. We loved having you with us. And again, this webinar will be up and living for a very long time on the We Honor Veterans website for any and everyone to access. All right, again, thank you everyone for joining us, and this will be up in the next couple of days. Thanks so much, Peter.
You're welcome. Thank you all for attending and have a good afternoon.
Take care. Bye.
Bye.